To the morning conference. I'm going to follow up on Dr. Stevens' lecture from a couple weeks ago on arthritis and really focus this morning on just showing a bunch of cases. It may not be terribly interactive, but I want to just go through a fairly large number of plain film cases of arthritis. I think this is one of the most challenging areas in MSK, and we have a reasonable volume of it that comes through here, but kind of the key take-home point is that it takes quite a bit of careful analysis and a good background on the clinical syndromes of arthritis in order to do a good job with the radiology. I just have really one text slide, then we'll get into the cases. The important thing to remember is that we tend to feel like we work in a vacuum, but we don't really, and we don't have great clinical information a lot of the time, but the diagnosis of different arthropathies is really a combination of the clinical features and the radiographic features. And a good clinician can really make a pretty good diagnosis of an arthropathy based on the things listed here, the patient demographics, what their history and symptoms are, what their risk factors are, things like, are they patient diabetic, are they immunocompromised, and do they have things like inflammation, fever, pain, and things like that. The overall distribution of the arthropathy or symptoms is really important too. So patient coming in with an acute monoarticular arthritis or joint swelling is different than somebody that has a symmetric distribution of kind of gradual onset of swelling and pain and so on. And there might be ancillary findings too, like patient may have a rash that may make you think of psoriatic arthritis, or they may have iritis, inflammation of the iris and conjunctiva. They may have discharge, they might have an obvious infection in a joint, or they may have some other kind of nasty kind of genitourinary discharge which might point you to a gonococcal arthritis. And they also have good lab tests, right? So basic things like sed rate, white count, serum markers, and many times they'll tap the joint if it looks like an effusion and send that for analysis for culture or for crystals. So there's a huge background that goes on maybe before we see the patients. And then we see the images and the selection process, whether the clinician actually gets images or not. And I would actually say that at Stanford, our practice in immunology is they're not really that imaging intensive. A lot of the diagnoses are made clinically and monitored clinically with just limited imaging. But when we do image, the things we need to think about are what's the distribution of the arthritis in the skeleton, both globally, like is it monoarticular, polyarticular, is it symmetric, asymmetric, and then within a given location, like the hands, we'll look at this. What's the local distribution? Does it spare certain joints? Does it affect joints specifically or symmetrically? And the other things that Dr. Stevens touched on, soft tissue swelling, are there joint effusions that we can detect? A real important thing is, what do the cartilage spaces look like, the space between the bones, because that lets us infer whether the cartilage is normal thickness or not. The presence or absence of erosions, that's kind of the key thing to bifurcate into something that's an inflammatory arthropathy versus non-inflammatory arthropathy. Are there soft tissue masses or lumps like that might be present in rheumatoid nodules or gout, things like that, and any calcifications in the soft tissue. So when I'm looking at arthritis cases, these are the things that we're focused in on, and we have this as the backdrop, hopefully more of this than less, but that's basically the key background that I want you to take away. So let's take a look at some cases here, and we'll just buzz through a number of cases fairly quickly. Just a normal shoulder, just to remind you of that normal joints should have nice smooth margins along the glenoid here, for example. Humeral head, nice smooth margins. The cartilage space is this space in here, and have certain normal thicknesses that we expect to see in normal situations. So lack of degenerative change, lack of osteophytes, lack of narrowing, makes us think that that's normal. If we look at this example, look at this lateral elbow, it's a fairly young patient, but if you look closely, and I'll try to be careful about window leveling things here, I think hopefully you can all tell that this patient has an effusion in the elbow joint. And so anteriorly, there's this lucency that's the anterior fat pad that's kind of bulging out. Probably more importantly is this subtle lucency back here, which is the posterior fat pad. So that tells us this patient has an effusion, and the most common situation we see that in is in trauma. And this patient actually had trauma, had some minor radial neck injury. But a patient with an arthropathy might just show up with an effusion without any trauma. So that's a radiographic sign that we should look for in arthritis. Having said that, different joints are better at others than showing effusion. So the elbow is a good joint to see effusions. We can see effusions to some extent in the ankle, not so much in the shoulder, not really in the adult hip. In the pediatric hip, we can see effusions and things like that. And in the hand and wrist, we can often see joint swelling that helps tell that there's probably an effusion. So simple things to start out here. Take a look at this example. So this is kind of classic bone board 101, right? So here's a patient coming through the orthopedic clinic, and this is fairly classic manifestations of osteoarthritis, right? So on the right side here, you have kind of asymmetric narrowing of the cartilage space. See how it's thinner here than here, maybe a little bit of osteophytosis here and here. And that side's like fairly mildly degenerated. On the left side, it's quite severe, right? So there's complete loss of cartilage space, and then there's the secondary signs of osteoarthritis, including sclerosis, some subchondral lucency, in this case, fairly large geographic lucency that's probably a large geode in the joint. Seen better here as you zoom in on this left hip and on the frog leg view. So advanced osteoarthritis in this example. The hands come through fairly frequently, and we tend to do a standardized exam where we do PA and ball catcher's views of both hands. And the key thing here is to just be systematic and look through each hand carefully for those signs of symmetry, joint space narrowing, and different degrees of arthropathy. So if we focus in on the right hand here in this patient to start out, let me just go to more proximally here. You want to look at the intercarpal joint spaces and the radiocarpal joint spaces. In this patient, they're fairly normal, kind of moving down into the MCP joints here, pretty normal, and they're fairly uniform as you go from 2 through 5 across here. As you go more distally, start to see some abnormalities, right? So this second digit is fairly normal here. This DIP joint starts to show some narrowing, small osteophytes. And these are more advanced here and here. And so we should know that when you're looking at arthritis, if it's more distal involvement without erosions, like in this, that's a pretty classic appearance for just osteoarthritis involving the hand. And that may be asymmetric in patients because of hand dominance. In this particular patient, it's fairly symmetric. The other thing this case brings up is whether there's actually an inflammatory component superimposed, or the inflammatory